Hello, my name is Belen Arnau, Customer Support Manager at Igenomix. I am pleased to introduce you to Professor Carlos Simon during the Endometrial Receptivity Right webinar session. Professor Simon is board-certified and full professor of obstetrics and gynecology at the University of Valencia, scientific director of EV and Igenomix, co-founder and co-scientific director of IBHEN. He has been recently appointed adjunct clinical professor of Stanford's University Department of Obstetrics and Gynecology. His basic and clinical research has contributed to the advance of reproductive medicine, specifically in human endometrial receptivity, embryo viability, embryonic implantation, and endometriosis. He has been awarded Prize Jaime I 2011 in medical investigation for his pioneering work in human endometrial receptivity disorders. Since 2001, he has expanded his research into the field of stem cells, resulting in the derivation of 10 human embryonic stem cell lines and the discovery of human endometrial stem cells. He has published a total of 334 papers in international peer-reviewed journals, adding up to an accumulated impact factor of 1,465,908. His papers have received a total of 10,701 CDs, with an average of 32% CDs paper. His age index is 57 and his editor of 15 books. His work has been funded through 35 projects, sponsored by public and private entities. He has been director of 28 philosophical doctor theses, and he is inventor of 13 patent applications, including the endometrial receptivity array. Igenomix is a company that provides advanced services in reproductive genetics. Our broad experience and qualifications make us one of the global leaders in this field, and we guarantee to offer effective solutions to various different infertility problems. The constant efforts we make in research and development, for which Professor Dr. Carlos Simon is in charge, enables us to create and develop specific tools to support professionals in the reproductive medicine field. We offer high-quality services in reproductive genetic diagnosis with one objective: patient satisfaction. We offer a pioneering team, high qualifications expert working to support the work of reproductive medicine professionals. Clinical experience. We emphasize our agility and speed in queries, reports, and results. Technology. We are the first to incorporate the latest technology worldwide. Research and development. Research and continuous innovation that make us an international reference. At the end of the session, you could take time to submit your written questions by using the webinar sheet feature. They will be answered by Professor Carlos Simon at the end of the session. Following today's session, the content will be also available at the Igenomix home website. Many thanks for your kind attention.
Endometrial receptivity array. The learning objectives of this webinar is to let you know about the relevance of the endometrial factor in human reproduction, to learn more about the endometrial receptivity array, and to discuss the clinical efficiency of personalized embryo transfer according to the endometrial status guided by this new objective diagnostic tool. If there is anything more sticky than a sticky embryo, this is a sticky blastocyst. In this image, you have the trofoectoderm of a human blastocyst showing you the microvilli that develop these adhesive properties of the embryo that is always present at a specific time point. Probably most of you, when you do the embryo transfer, your embryologist will double check the fact that the embryo is not remaining attached to the plastic. Then if this is so clear, if the embryo is able to attach any place, including the plastic catheter, why the embryo is not working properly in the place that it should be, which is the human endometrium. The reason for that is well known, and it's because the endometrium is non-receptive to the human embryo most of the time during the menstrual cycle. In other words, only a few hours, a few days, the human endometrium turns to be receptive for the addition or the attachment of the human blastocyst. This is called the window of endometrial receptivity, and has been classically, we thought that this was about 2 to 3 days, either 7 days after LH surge or 5 days after progesterone administration, either endogenous or exogenous progesterone administration. And we always believed that the window was always there at the same time without any modification regardless the patient's situation. This is what the classical knowledge indicates us. Now, but the real issue is that we do not have any endometrial diagnostic tool that can inform us about endometrial receptivity. You all know about the Noyes criteria that indicate us the dating of endometrial biopsy. However, recent randomized studies demonstrate what was always suspected, which is that there is a huge interobserver and cycle-to-cycle variation, more than 60%. And endometrial dating is not related at all to the fertility status. For that reason, today, histological dating cannot be used as a valid method for the diagnosis of the luteal phase deficiency, neither guidance throughout clinical management in infertility. And therefore, we are still orphans at the time to diagnose, to really look for the endometrial factor in human reproduction. Now, what can be done in order to progress in the sense that to have a diagnostic tool? We can take advantage of modern technologies. We can take advantage of omics in the sense that go deeper either in the DNA, RNA, proteins, or metabolites produced in order to be able to detect what is the signature of endometrial receptivity. The DNA can be used, but this only detects DNA that is always there. The mRNA, the transcriptomics, is the most important candidate due to the development of the arrays, and also because other organs, other function has been already investigated using this transcriptomic signature. The proteomic is algo that is coming in the future, but is not as advanced as the transcriptomics yet. And the metabolomics, again, is something that is coming, but is not really affected nowadays. The transcriptomics, as mentioned, it is a long experience nowadays in using the transcriptomic signature, for instance, to detect tumor classification in order to grade the tumors, and it makes difference between death and life concerning this classification, this molecular classification of the tumors. And because of that, it has been used for different kind of disciplines in medicine. This is just a brief summary to show in 2007 the knowledge of the transcriptomics in the human endometrium, and this is just to show the work that my group has been done in the last 10 years trying to progress in the understanding of endometrial receptivity during the window of implantation, in stimulated cycles, or even with an IUD inside that was inducing a refractory endometrium. So we were able to understand the endometrial receptivity from the optimal, suboptimal, and refractory point of view. We can have this. We also published this paper in which we just investigate the profiling of the endometrial receptivity during the window of implantation in natural versus control ovarian stimulated cycles in 50 patients, and we obtained biopsies throughout the luteal phase, and we compare all of them in natural versus, again, a control ovarian stimulated cycle. So we learned what was the difference in endometrial receptivity in these two types of situation, and also we were able to profile the pre-receptive versus the receptive gene signature that was very helpful to develop the next diagnostic tool, which is the endometrial receptivity array. This array, the basic publication was published in 2011, and this is a customized array composed by investigating 238 genes, which is composed by 569 probes, with 8 copies per probe. This is using an Agilent commercial platform, and this is the format, has been already also patented. And this customized array, as you can see there, is coupled to a bioinformatic tool that is able to analyze the data, and at the end is producing a classification and prediction from this gene expression, indicating us whether an endometrium is receptive, pre-receptive, post-receptive, or proliferative. So without any knowledge about the histology of the sample, with this tool that is based on the genomic signature of endometrial receptivity, the classification is able to let us know whether this endometrium is in these phases, either receptive, post-receptive, pre-receptive, or proliferative, guiding the way that we will transfer the embryos in a personalized manner. Now, in order to do this diagnostic tool has been prepared from endometrial biopsies obtained either in a natural cycle or in a hormonal replacement therapy cycle. In a natural cycle, typically the biopsy must be taken at LH plus 7, but we must be sure that the LH search was properly picked up either in urine or serum. And in a hormonal replacement therapy, the initial biopsy must be taken after 5 days of progesterone administration, of course, with previous estradiol priming. This is the same kind of cycle that we use for ovum recipients. So these are the two ways that the biopsy must be taken. This array is not intended to be used in control ovarian stimulated cycles, because we know, and has been demonstrated and published in 2008 in JCM as mentioned, that in control ovarian stimulated cycles, the genomic profile of the endometrium is altered, is not the one that is the optimal one that is in the natural or hormonal replacement therapy cycles. Therefore, this diagnostic tool was intended to investigate the endometrial receptivity in patients either in a natural cycle or hormonal replacement therapy cycle, and then the transfer must be done at these specific cycles and timing in a personalized manner, and this is crucial. Now, this is just to show you a few slides of why the natural cycle is not as trustable as we believe from the beginning. And that's why we are moving more and more to the hormonal replacement therapy cycle. As you see in this paper from Direito and colleagues, there are LH search variants. Therefore, sometimes you can have two LH peaks, an LH peak and a plateau, so this could complicate the way that a natural cycle can be started. Also, in this another slide, you can see that this is the ovulation diagnosed by ultrasound refer to the LH peak. Again, ovulation as by ultrasound can be referred as previous to LH peak, can occur in the middle of an LH peak, or can occur after the LH peak, or even between two LH peaks. So again, what we always believe as a dogma, the 36 hours after LH peak, this can change. And therefore, we suggest more and more to go to the hormonal replacement therapy cycle. And as you will see in the presentation, the reason is the endometrium is always the same. What is changing is the hormonal cycle that the patient has. And therefore, if we can do a homogeneous hormonal cycle in the patient, then we are going to have the same expression in the endometrium cycle to cycle. That's the point. The endometrial receptivity array diagnosis, you will have the results. The interpretation is either receptive, which means that it's recommended to the doctor to proceed with the embryo transfer at the same, using the same protocol, natural or HRT cycle, at the same day indicated, or if it's non-receptive, is letting you know whether the endometrium will be pre-receptive or post-receptive. And then you have to wait one more day or add one more day of progesterone previous to the next endometrial biopsy to assure that the displacement of the window of implantation was there. The main questions that we have from the beginning was how accurate is this diagnostic tool based on the endometrial genomic signature. So the accuracy was already published in this paper by Diaz-Jimeno et al. And Fertility and Sterility, and this was a blinded study in which we demonstrate that ERA classifies far much better than Noyes criteria. We did this again, pathologist 1, 2, and the two pathologists or the ERA test. As you can see, and this is according kappa values, the accuracy was higher for the ERA test, and we have an excellent concordance in the pre-receptive, receptive, and post-receptive endometrium. The only part of the cycle where the anatomy, the histology, was better was in the proliferative cycle, and of course, because we aim to transfer the embryo, this part of the cycle is not important for us. And the other question was, how consistent is this diagnostic test? To demonstrate consistency, what we did is to analyze in the same patient, we performed two endometrial biopsies that they were basically 40 months apart. So in the same patient, an endometrial biopsy was obtained and a specific day analyzed, and the patient come back again the month that you have there, being the maximum analyzed 40 months. In all the patients investigated, the ERA test was completely consistent and reproducible up to 40 months later. Therefore, the message is, if this diagnosis, whether it's receptive or is pre-receptive, it will last regardless that is next month or next year or 40 months later. This is just to show you, this is in the publication, how close these biopsies cluster together even after those months apart after sampling. And finally, what I want to show you is the clinical results that has been already published in 2013, Fertility and Sterility, about the use of this test, the ERA test, in patients with repeated implantation failure. This is table 1, in which you can see this is a prospective non-randomized trial in which 85 patients with recurrent implantation failure and 25 patients as a control were investigated using this test. Previous failed cycles mean 4.8 is about 5 previous implantation failure, 5 previous cycles, so they were difficult patients compared to control patients in which they start their first endometrial, their first IVF cycle. Now, the first results obtained in this study was that In patients with recurrent implantation failure, 74% of them, they were receptive. In other words, 1 out of 4 of patients, the window of implantation was displaced. So in 25.9% of the patients, the window of endometrial receptivity was not at the place that it should be. And therefore, in 1 out of 4, the cause of this failure could be that the endometrium was not at the receptivity status that we expected. This is in contrast with the control group, in which just only 12% of the patients were non-receptive. The window of endometrial receptivity was displaced in 12%, which is the mean, which is what we have found already in the general population. And what happens with patients that we just follow the guidelines indicated? So in this study, 29 patients with recurrent implantation failure in which a receptive endometrium was found, then we follow the transfer in the next cycles using frozen embryos at the time that the biopsy, that the ERA test indicate that it was receptive. And with that, we obtain the implantation after the first personalized embryo transfer. Personalized embryo transfer design is defined by the transfer guided by the ERA test. The embryo was transferred at the moment that the ERA test indicates that it was receptive. So by doing this, we have a 33.9% implantation rate in recurrent implantation failure versus 55% in control patients, and the pregnancy rate was 51%. So 33 implantation rate and 51 pregnancy rate in those patients with recurrent implantation failure seems quite good compared to their situation, because they have previously failed 5 previous IVF cycles. And we just did this, transferring the embryos in due time when the ERA test indicate that it was receptive. Now, the question arises because you know about the scratching case, and whether scratching the endometrium before IVF could improve results. So to dissect out the possibility that the effect that we have seen in those patients with implantation failure was due to the scratching phenomena, because we did, in order to have the ERA test, we have to obtain a very small amount of endometrial tissue. Then, in order to dissect out this effect, what we did is to analyze implantation rate and pregnancy rate in the first transfer, in the first embryo transfer, and we did that in our patients. The patient comes to receive the embryo anytime it was not already indicated, so they can come in the first, second, third, fourth, fifth, or 6 months after the ERA test. As you see, the implantation and pregnancy rate were fairly the same all over these timelines. If something, the numbers are low, but if something can be understood here, is that the month after the endometrial biopsy, when the patient comes 1 month after that, the implantation rate and pregnancy rate was lower. So this is just to demonstrate that the mechanical scratching phenomena during the endometrial biopsy is not adding any value to this improvement of pregnancy and implantation rate. So this will be just purely because the diagnostic test, and not because the mechanical removal of the endometrial tissue. This is just to, next slide, just to show you an example in the same patient of how can we progress, and this is done throughout what we call a PCA, a principal component analysis data, in which after 4 days of progesterone, the endometrium still is pre-receptive, and day 5 still is pre-receptive, and only at day 6 the endometrium can be classified as a receptive. This kind of tools is what we are using based on this transcriptomic signature. And now, let me show you what happens in those patients that they have a non-receptive endometrium, patients with recurrent implantation failure, in which the endometrium was non-receptive, corresponding to 25% of patients with recurrent implantation failure. We investigate 25 patients with a non-receptive endometrium. They have, in this subgroup, the previous failed cycles were 5.0, and this was 0.3 in the control group. Interestingly, when we detect this non-receptive, the majority of the patients, they were classified as pre-receptive, although we have also 60% of them that they were post-receptive, meaning that they need more days of progesterone to achieve endometrial receptivity, or this window has already passed. So what we did is to do a second ERA test to identify this, and 15 patients we could demonstrate that it happens, and finally in those patients we transfer now the embryos according to the diagnostic test, which means that a blastocyst was transferred either after 7 days of progesterone or after 3 days of progesterone, or a day 3 embryo transfer could be replaced either after 5 days of progesterone or after 1 day of progesterone. This is called personalized embryo transfer, which means that now the embryo transfer is done according to the endometrial characteristics, to the endometrial timing, and not to the embryo phase. The embryo phase must be accommodated to the status of endometrial receptivity in those patients with displaced window of implantation. And by doing this, as you can see, there is a implantation rate of 38.5 and a pregnancy rate of 50%. Again, is something that we have not done before on purpose, which is transfer the embryos according to the endometrial receptivity status. This is just one case report that is going to be published in Human Reproduction in this year, in which we have this patient coming from 2 previous IVF treatment. Then in our center, we decide to continue doing IVF, now transferring day 5 embryos, either in a hormonal replacement therapy cycle or in a natural cycle. Then, because everything was failed, we moved to the ovum donation program, and in the ovum donation program, we did a transfer at day 3 using a hormonal replacement therapy cycle after 2 days of progesterone. Then we try in a natural cycle. Then we try again with blastocyst in HRT cycle after 5 days of progesterone. And after these serious failures, we just did an ERA test on this patient, and we find out that it was a pre-receptive endometrium, and the window was displaced 2 days. And because of that, what we did is just to transfer the embryos, in this case day 5 blastocyst, after 7 days of progesterone, and the patient has successfully pregnant. In fact, she has a twin pregnancy. This is just an example of a case report that is published, and this is a pilot study showing you that in about 17 patients that we have already tested for that for severe implantation failure, in those patients we have, although they have a very low pregnancy rate, none of them continue the pregnancy, as you can see here, from a clinical abortion of 100% after those implantation rates. And this is just the first attempt, and this is the accumulated failures. The patient became pregnant, but either they have a clinical abortion or a biochemical pregnancy, but none of these patients progress to term. In those 70 patients, we did the ERA, and we find out that there was a displacement of the window of implantation. either a pre-receptive endometrium, and some of them they have a delay of 1 day, some of them they have a delay of 2 days, or a post-receptive, and some of them they have an advance of 1 day. What we did is to do personalized embryo transfer of these 70 patients, and now at the first attempt we got a 52% pregnancy rate with an implantation rate of 34.5, and we have biochemical pregnancy of 3 patients, and you can see also the accumulated pregnancy rate was 60% with 40% implantation rate and 25% biochemical pregnancy. This is a subgroup of patients, this is a pilot study that we obtained in patients with severe implantation failure, in which they have a demonstrated displacement of the window of implantation, and by correcting this window, this displacement, by doing a personalized embryo transfer, now we raise pregnancy and implantation rate to the normal levels. Again, this will be published in 2014 in Human Reproduction. So, the point that we want to make with this new diagnostic tool is that we believe always that the window of endometrial receptivity was always there, constant in all of our patients. And we believe that this was at progesterone plus 5, which is the moment where a blastocyst will attach. And therefore, if we transfer a day 3 embryo, the day 3 embryo will have to be replaced after 3 days of progesterone. But now what we know is that in some patients, probably 25% in patients with recurrent implantation failure, in some of these patients, the window will be delayed or will be advanced. And in some of them, the window will be narrow. So this is the way that we can personalize the embryo transfer by following exactly what is mentioned about the ERA test. Again, we used to do always the embryo transfer at the same day of the progesterone administration or LH peak, but now the point is to do a personalized embryo transfer, which is guided by the personalized window of endometrial receptivity in each patient that can indicate that we can transfer the embryo at different days of progesterone administration. So, in conclusion, is that in patients with implantation failure, 1 out of 4 of them approximately will be non-receptive, and therefore, by doing another ERA test, we can find the displacement of this window of implantation, and then we can transfer in due time, which is now the personalized embryo transfer. In conclusions, the ERA test diagnosed the time of endometrial window of implantation. The reproductive outcome in risk patients with receptive ERA is comparable to the general IRT populations, and the non-receptive patients diagnosed with the endometrial receptivity array, they have the window of implantation displaced, and personalized embryo transfer improve clinical results. Now we are working on the clinical validation of the ERA test in the first appointment in an international multi-center randomized clinical trial to find out whether this could be a diagnostic test to be used to understand the endometrial factor just in the first appointment. What the design of this study, as you can see, is basically to compare the results of using Group A, which is fresh embryo transfer, Group B, which is delay or defer embryo transfer, or Group C, which is to do personalized embryo transfer by having the ERA investigated before, and then to guide the embryo transfer in those patients according to their displacement of the window of receptivity. Thank you.
Thank you again for your kind attention. Now you may direct your questions to Professor Carlos Simon. They will be answered in reading through your own screens. Thanks a lot for your attention. Hope that you have enjoyed the webinar and see you soon.